Imagine a world where the greatest scientific achievement of a generation, a vaccine capable of ending a global pandemic, is finally within reach. Scientists work around the clock with 40 clinical trials in motion and nearly 100 more in the pipeline. The finish line appears imminent, yet a stark contradiction emerges. Nearly 35% of the population declares they will not take the shot. Among certain demographics, that refusal rate climbs over 50%. In an era where polio and smallpox are merely ghost stories of the past, modern medicine is treated with unprecedented suspicion. To the uninitiated, the medical request sounds like a plot from a science fiction thriller. A dangerous virus is modified or killed to ensure its safety and then injected into a child's arm. Without the lens of trust and scientific literacy, this is not a routine procedure, but a terrifying leap of faith. While headlines frequently highlight the rise of activists and new outbreaks, the actual rate of vaccine refusal has remained remarkably stable for years. This suggests that the real battle is not merely about a vocal minority or a lack of information. It is a struggle rooted in the psychology of decision-making under fear. Health officials are increasingly realizing that simply providing facts may be the least effective way to save lives. This situation presents a visceral image. On one side stands the pinnacle of human ingenuity, a molecular miracle in a glass vial. On the other stands the human brain, which has not received a biological update in 50,000 years. Public health is often treated as an engineering problem, operating on the assumption that if a bridge is built, people will naturally cross it. However, many are standing at the edge, looking down in terror, or remaining entirely uninterested. Human decision-making is not a spreadsheet of calculated risks and benefits. It is a biological war occurring inside the mind between immediate gratification and future safety, a contest where the future usually loses. This mechanism dictates choices far beyond vaccines, mapping the invisible architecture of daily life, from choosing a donut over an apple to procrastinating on a medical checkup. While procrastinating on taxes results in a fine, procrastinating on a pandemic response yields exponential consequences that ripple through an entire society. The concept of delay discounting measures how much an individual devalues a reward because it requires a wait. Evolutionarily, this is not a flaw, but a survival mechanism. For a hunter-gatherer, a meal today is a certainty, while tomorrow is promised to no one. The brain is hardwired to seize the now because the future is inherently uncertain. The impulsive limbic system, the lizard brain, demands immediate sensory satisfaction, sugar, safety, and reward. Meanwhile, the executive prefrontal cortex attempts to whisper plans for the coming winter. In this internal dialogue, the impulsive system often drowns out the executive. Research involving nearly 7,000 people across 13 countries confirms that a high rate of delay discounting, being short-sighted, is a significant negative predictor of vaccination. To an impulsive brain, the vaccine is a poor transaction. The process involves immediate, tangible costs, waiting in line, the pain of a needle, and the potential for a day of fever or chills. The reward, by contrast, is the absence of a future illness, an abstraction that is invisible to a mind wired for immediate feedback. A fascinating contradiction exists within the hygiene paradox. Individuals who refuse the vaccine due to short-sightedness are often more likely to obsessively wash their hands and clean surfaces. This behavior is rational when viewed through the lens of the reward system. Cleaning provides immediate sensory evidence, the sight of crumbs disappearing and the scent of bleach. This triggers a dopamine hit that signals control and safety, lowering anxiety instantly. The vaccine offers no such immediate proof of efficacy. For these individuals, safety must be tangible. They need to smell the bleach to feel secure. The environment interacts directly with this cognitive wiring. In countries with strict mandates, such as France or Italy, short-sighted individuals remained highly compliant with social distancing because the punishment, a fine or confrontation with authority, was immediate. The abstract threat of the virus was replaced by the very real threat of a police officer. In the United Kingdom, where restrictions were looser, this behavior collapsed as soon as the immediate stick vanished. The abstract, long-term threat of the virus was insufficient to maintain compliance. These traits are not temporary states of mind, but stable personality characteristics. Longitudinal studies of adolescents in Los Angeles show that high school seniors who demonstrated high impulsivity in 2016 were the same individuals hesitant to vaccinate 5 years later in 2021. This hesitancy is mediated by two specific traits: complacency and a lack of collective responsibility. The healthy young adult feels invincible today, discounting future risks to zero. Furthermore, the abstract concept of herd immunity fails to trigger a dopamine response. For the impulsive brain, a shared reward for the community 6 months in the future is an insufficient incentive to endure an immediate cost. Human perception is further distorted by the availability heuristic, which suggests that if an example is easily recalled, it must be common. While shark attacks are statistically rare compared to accidents involving vending machines, the vividness of the former dominates the imagination. During the pandemic, media attention created a powerful feedback loop of fear. While only 7% of deaths occurred in those under 55, public estimates place that number at 43%. This distortion occurs because a healthy young father dying is a gut-wrenching headline that sticks in the brain, while the expected death of an elderly individual remains a statistic. This heuristic also works against the vaccine. As a virus is perceived to become milder, the vivid stories of rare side effects, a neighbor's blood clot or a forum post about inflammation, become the dominant available narrative. The internal risk calculation flips, and the cure begins to seem more dangerous than the disease. This leads to the echo chamber effect, where confirmation bias is amplified. The fundamental human need to belong to a tribe often overrides rational assessment. If a community dictates that we don't do that here, the social cost of being ostracized feels more immediate and dangerous than the virus itself. Often, resistance is not a matter of deep-seated belief, but of real-world friction. Consider a young mother in a bustling urban center navigating a complex healthcare system while balancing a grueling work schedule. She is not an ideologue. She is exhausted. For her, a free vaccine is not free if it requires 4 hours of childcare and 2 bus transfers. When a vaccine is not a mandatory requirement, it becomes just another hurdle in a life already filled with them. This highlights that the gap in vaccination is often a gap in access. Personal choice is a luxury defined by convenience. Nudge theory suggests that to encourage a behavior, one must make it the path of least resistance. Simple text reminders remove the cognitive load from fallible human memory. Framing a shot with urgency or scarcity, such as citing limited doses, utilizes basic marketing to drive public health. Even a small financial incentive can balance the equation for those focused on immediate rewards. However, the most powerful nudge, default enrollment, is a double-edged sword. In low-trust, polarized environments, being automatically booked for an appointment can trigger reactance, a psychological pushback against a perceived threat to autonomy. In such context, a default feels like coercion, causing individuals to reject the shot out of a desire to reclaim their agency. Mobilization efforts in other societies offer a different model of social architecture. In cities like Shanghai, the grid management system utilizes hyper-local trust.
A retiree who is a respected fixture in his apartment block becomes the face of the campaign. He is not a distant scientist. He is the man who plays chess in the park. This system leverages personal relationships to deliver institutional messages, bypassing the individualistic paralysis often seen in the West. Paradoxically, in these systems, private sector workers are often more responsive to government signals than those with guaranteed job security. Those with the iron rice bowl of state-guaranteed health and pensions can afford complacency. The private sector worker, whose situation is more precarious, views the government signal as a vital cue for survival. If they cannot work, they cannot eat. Their compliance is a form of rational risk management. Effective mobilization also requires framing that aligns personal instincts with collective goals. Slogans like "home is the smallest country" bridge the gap between the individual and the state. It suggests that one is not vaccinating for an abstract nation, but for the protection of their own family. This effectively aligns the selfish gene with the goal of public hygiene, making the nation feel like one extended family. Public health is far more complex than the directive to trust the science. Science provides the tool, but psychology, sociology, and storytelling provide the user manual. Humans are not broken calculators failing to compute data. They are responding rationally to trust, fear, and social identity. To save lives on a massive scale, the social architecture must be designed for the brain as it exists. One built for the savannah, now navigating a global crisis. The next breakthrough in human survival may not come from a petri dish, but from a deeper understanding of the invisible architecture of the human mind.